To kick off this year's, I don't know, this academic, we can call it our academic year, AKMG academic year's education committee activities. As you all know, Dr. Khalid Ashraf and Dr. Rojimon Jacob have been leading these efforts for the last year, and we've had some amazing sessions, and we were able to get a lot of CME credits for this. Also, kudos to Dr. Subrabhat, who put this series together, and we were able to get the CME credits from Piedmont. We've continued that tradition for this year. So this will be the first of several journal clubs that we hope will serve two purposes at least. One would be to keep us up to date on different topics, and the other one would be to bring in and give opportunities for members to present either their work or for younger members to present other good work from prominent journals. We are fortunate that we also will have several faculty members who will be chipping in and helping with both the analysis as well as the statistics work. So it's my pleasure to introduce the host of today's journal club, our co-chair of the education committee, Dr. Rojimon Jacob, who is currently the professor of radiation oncology and head of GI oncology division at UAB. And he serves on the GI committees of several associations, including the Astro RTOG, NRG. He's an examiner for the American Board of Radiology. He's an alumnus of Trivandrum Medical College. Following his training in the RCC, he went on to do his FRCR from Royal Marsden NHS in London, and followed by fellowship at the Fox Chase Cancer Center. So very well qualified. Finally, he did an MBA from UAB as well. So well overqualified, I would say. But it's good to have you, Roji, and please take it from here. Thank you very much for doing this.
Thank you, Nigel. We are extremely pleased to kick off our educational session today with the Journal Club. Today's stars are Dr. Surya, Suresh, and Dr. Johnson, who I will be introducing shortly. For the first presentation, Dr. Surya Suresh will be talking about a recent publication in the New England Journal, 24-hour urinary sodium and potassium excretion and cardiovascular risk. Dr. Suresh is a graduate of Thanjavur Medical College in India. Following her medical training, she worked as a general practitioner in India for a while before moving to US. Currently, she's placed in Sarasota, Florida, where she's doing some research in preventive cardiology at the Cardiovascular Center. She's actively seeking for a residency position in the US, and we hope this would be a great experience for our young AKMG member. So welcome, Dr. Suresh. For this talk, we have two faculty mentors. One is Dr. Madhu Bhaskaran. Dr. Bhaskaran is a professor of medicine. He's a Calcutta Medical College and PGH Chandigarh alumni. He works as professor of medicine in the division of kidney disease and hypertension with the Northwell system in New York. And we also have Dr. Rajan Krishnamani, who's also a Calcutta Medical College alumni. He is a specialist in non-invasive cardiology and advanced heart failure, presently working for Premier Health in Dayton, Ohio. They have both been extremely kind to extend their help and expertise for our first paper. So over to you, Surya.
So I'll share my screen now. Are you able to see this? Okay.
Yes, we can.
Okay, so welcome all to the AKMG Online Journal Club. I am Surya Suresh. Today's article is really interesting with amazing statistics, so let's begin. The title is 24-hour urinary sodium and potassium excretion and cardiovascular risk. It was prepared by Yuan Ma and colleagues. It was published in the New England Journal of Medicine on November 13, 2021. Let's talk about the background. We all know that high sodium intake leads to hypertension and subsequently cardiovascular disease. So it's a leading dietary risk factor for increased morbidity and mortality from cardiovascular diseases. The relation, however, it's controversial. Some researchers claim it is a J-shaped one, whereas some others claim it is a linear relation. This is because of the inaccurate assessment of sodium intake. But at the end of this presentation, you'll be able to answer this question. A single measurement like a spot urine or a single day 24-hour urine sample is inadequate because of significant change in the day-to-day consumption of sodium. Some days we have a biryani or some days we eat salads. So it's natural. The study has investigated the relationship between sodium and potassium intake and cardiovascular risk by using multiple 24-hour urine samples. Multiple 24-hour urine samples is the gold standard for statistics for identifying the sodium intake. Moving to materials and methods, the study population. The study included individual participant data from 6 prospective cohorts of generally healthy adults who didn't have any cardiovascular disease or kidney disorder. The 6 studies are enlisted here: the Health Professionals Follow-up Study, Nurses Health Study, Nurses Health Study 2. These 3 studies were conducted among health professionals and registered nurses in the United States. Then there is the PREVENT study, which is prevention of renal and vascular end-stage disease study, conducted on which is a population-based study. There is trial of hypertension prevention 1 and 2 follow-up studies as well. The baseline, it was defined by the period during which the pre-specified number of 24-hour urine samples were obtained. And here the researchers excluded the first year of follow-up because the dietary information close to a cardiovascular event does not necessarily indicate a person's habitual sodium intake. So that's a smart move by these researchers. Among the 11,435 participants, after taking off those who didn't follow up or has followed up for less than 1 year, the number came down to 10,709, which is pretty large. So this is a large-scale study. The 24-hour urinary sodium and potassium excretion was calculated by averaging the samples per participant. In order to avoid errors, the study excluded samples that met at least one of the following criteria. That is volume less than 500 ml or volume more than 5 liters, a duration less than 20 hours or more than 28 hours. And if the volume loss was recorded and it was more than 100 ml, the sample was excluded. The outcome the researchers were looking forward was a cardiovascular event, which can be a coronary revascularization like a CABG or PCI, or a fatal or non-fatal myocardial infarction or stroke. Coming to statistics, the primary analysis evaluated the association between urinary sodium and potassium excretion, and also the combination, that is the sodium to potassium ratio with subsequent cardiovascular event. They assessed the relation in each study using a consistent analytical method to create the results using a random effect meta-analysis, which was a 2-staged pooled analysis. Hazard ratios, it was calculated using the Cox proportional hazard models 1 and 2. The model 1 is partially adjusted model with adjustment for potential confounding factors like age, sex, and race, whereas the fully adjusted model, that's the primary analytical model, it has additional adjustment for education level, height, BMI, smoking status, alcohol consumption, physical activity, history of diabetes, elevated cholesterol status, family history of cardiovascular disease, and also 24-hour urinary potassium excretion when sodium was considered as the exposure, and 24-hour urinary sodium excretion when potassium was considered as the exposure. And coming to the results, among the 10,709 participants with a mean age of around 52 and whom 54% were women, there were 571 cardiovascular events during a median follow-up of 9 years. The incidence rate was 6 per 1,000 person years. The median 24-hour urinary sodium excretion was calculated as 3,270 milligrams. The median sodium intake was calculated as 3.5 grams per day, and the potassium intake was calculated as 3.3 grams per day. This is the forest plot for the association of 24-hour urinary sodium and potassium excretion and sodium to potassium ratio with cardiovascular risk. A forest plot brings all the results from different studies together in a meta-analysis in a graphical representation. I'll let you know how to read this now. Here, this is comparing per 1,000 milligram increase in 24-hour urinary sodium excretion with cardiovascular disease. The studies are listed on the left side, and the graph. This is the graph where you can see the results aligned together, and the corresponding numerical results, which is the same, are present here. Here it's the statistics, and we have to make sure whether these different studies can be combined in a meta-analysis. For that, you need to check the heterogeneity I-square value. Here is 2%, which is low. That means there is less difference among these studies and that they can be combined together in this meta-analysis. So let's look at the graph here. There is a vertical line, which is called the line of no effect, and that's placed on the value where there is no association between the exposure and outcome. Here, the value is 1. And the lines, the horizontal lines indicate the confidence interval, 95 percentile. And the median is given as a small box. The size of the box indicates the weight of this study in the meta-analysis. The overall effect is given by a black diamond at the bottom, and the corners indicate the confidence interval. And here it is the overall result, which is 1.18 here. And we have to make sure that the edge does not touch the line of no effect. That means the value 1. And since it is not touching, and since the confidence interval does not include the value 1, this result has statistical significance. So the meaning is per 1,000 milligram increase in 24-hour urinary sodium excretion is associated with an 18% increase in risk for cardiovascular disease. Now you can read this table yourself. It is comparing per 1,000 milligram increase in 24-hour urinary potassium excretion with hazard ratio for cardiovascular disease. Again, here, if you're looking, all these studies, the median values are falling to the left, and the overall effect here is 0.82, which means per 1,000 milligram increase in 24-hour urinary potassium excretion is associated with an 18% decrease in cardiovascular risk. When they have combined sodium and potassium together, the overall effect is 1.24, which means a 24% increase for cardiovascular disease. So this means when a person is having high sodium intake and low potassium intake, there can be an additive risk for increased cardiovascular disease. This is blind plots, which is the most interesting part of this presentation. Here you are also again comparing per 1,000 milligram increase in urinary sodium potassium excretion and also the sodium to potassium ratio with hazard ratio for cardiovascular disease. You can see with per 1,000 milligram elevation, there is a linear increase in the hazard, where the p-values in all these studies are less than or equal to 0.005. And here, when you're comparing potassium excretion with hazard ratio for cardiovascular disease, it's decreasing linearly. And again, the sodium to potassium ratio, as it increases, the hazard also increases, and it's even higher than the first part. So if you're comparing the lowest and highest quartile here in the first part and taking a median at around 4.7 grams, the hazard ratio comes at around 1.6, which means around 2 to 3 more cardiovascular events per 100 people. And if you're coming here, comparing the potassium excretion, taking the lowest and highest quartile and the average value of around 3.5 grams, the hazard ratio comes at around 0.7, which means one fewer cardiovascular event per 100 people. The researchers have also done a subgroup analysis. Here, the groups are divided based on the age, sex, baseline hypertension, weight status, and years of follow-up. And you can see that regardless of these different subgroups, there is consistent increased hazard ratio per 1,000 milligram increase in 24-hour urinary sodium excretion. Again, if you're comparing per 1,000 milligram increase in 24 urinary potassium excretion, there is consistent decreased risk here. Per unit increase in sodium and potassium ratio is associated with an increased risk, just like the forest plot. This is the summary of the results. Higher sodium excretion, lower potassium excretion, and higher sodium to potassium ratio were all associated with a higher cardiovascular risk in this analysis, which was controlled for other confounding factors. That means the p-value was less than or equal to 0.005. And each daily increment of 1,000 milligram in sodium excretion was associated with an 18% increase in cardiovascular risk, whereas each daily increment of 1,000 milligram in potassium excretion was associated with an 18% decrease in risk. There are limitations for the study. Even though the researchers has significantly controlled the heterogeneity, there is inherent heterogeneity in the original studies. There are potential residual confounding factors like dietary information, socioeconomic status, about which only few studies were able to provide the correct information. There can be within participant variation in sodium excretion. This can lead to underestimation of the actual association. And finally, generalizability. The study was conducted among healthy white population, so the results cannot be applied for people belonging to other race or who has certain health conditions. And coming to a conclusion, we are able to answer it. The study showed a significant linear association between sodium intake, and it was measured using the gold standard, that is the multiple 24-hour urine samples. And the risk is in a dose-dependent manner with a daily sodium intake of around 2,000 to 6,000 milligrams. The American Heart Association recommends a sodium intake of less than 2,300 milligrams. So this study strongly supports the current recommendation. Higher potassium intake was associated with a lower cardiovascular risk. There is a recent interesting randomized controlled trial which has shown that potassium source substitute significantly reduced cardiovascular events and death in a high-risk population in China. So if you are combining the results together, you can definitely consider offering your patients who are both elderly and middle-aged to follow a medium sodium restriction and high potassium intake for primary prevention of cardiovascular disease, among whom kidney function is normal. And that's the end. And thank you so much for being here. And thank you for listening to me.
Thank you, Surya. That was a fantastic presentation of a rather important topic. You broke down the presentation very well and described the statistics in an outstanding fashion. So kudos to you. Now, before we open the paper for general discussion, in the interest of time, I would like to get the expert opinion from our faculty mentors. Dr. Rajan and Dr. Bhaskar are on standby. Dr. Rajan, do you want to go first and give your valuable opinion, please?
Thanks, Dr. Suresh. It's an excellent presentation. So a couple of pointers. One, this is a well-conducted study with a lot of statistics, and it makes it very difficult to really get to the bottom of it. But we still know, based on multiple epidemiological studies, that there is a correlation between increased sodium intake and cardiovascular risk. And the thought process was that it is primarily because of hypertension, and that the primary event with increased sodium intake is hypertension, and hypertension increasing the risk of coronary artery disease and stroke. Now, One correction, the AHA recommendation for sodium intake is 1500 milligrams per day. The average US intake is around 3,400, and the US, Dietary Association, their recommendation is less than 2,300. So even when we say these numbers in simple terms, it basically 1 teaspoon of sugar is 2,325 milligrams. So the way to think about it is 1 teaspoon of sugar, teaspoon of salt per person is what we are looking at in terms of per day intake. Okay, so that is one. And the second thing is one thing I found interesting is when I look at the baseline demographic data, even though this is supposed to be a healthy population, there is a significant incidence of hypertension, baseline hypertension of around, I think, 20-25% on the baseline data the trialists have provided. So again, it is not the most healthy group, even though these are healthcare professionals, so to speak. The current thing is that there was another trial as well, a meta-analysis that was published in Lancet, which showed that a 5 millimeter decrease in blood pressure is associated with around 10% decrease in cardiovascular risk. This was again published earlier this year in Lancet. So everything goes together, and the estimation of urinary excretion is probably a surrogate way to look at the total salt intake.
Thank you, Dr. Rajan. Dr. Bhaskar, do you want to chip in?
Yeah, sure. I just want to first congratulate Surya for a fantastic presentation. I mean, it took true grit to go through this article, and tease out all the findings and say, explain everything in a very, very nice way. And great job. And I agree with a cardiologist, expert commented, about the intake, and I just want to point out a couple of things. One is, Dr. Salim Yusuf did a very large study, which is similar, somewhat, 95,000 people in 21 countries, a prospective study of sodium intake. It was published in Lancet in 2018. And, if we had Anna Matthew or Dr. Salim Yusuf from McMaster were on the, Journal Club, they would have been real experts, on this topic. But what they found is sodium decrease was, really made a difference in countries where the sodium intake was more than 6 grams. But in this study, in that study, they only did a spot sodium, urine sodium. And here they did a, 24-hour excretion. And they also found that potassium intake, any increase also helped decrease cardiovascular event and stroke. One of the things they try to do in the study is to combine the sodium and potassium intake, the urinary excretion being surrogates for that, and combine them to see if they can improve the, say, for example, ROC curve of that particular, ratio. Is it better than just using the sodium intake or potassium intake? But it didn't really help because these patients had normal kidney function. They excluded all the patients with chronic kidney disease. So sodium intake, when you decrease it, there is less potassium excretion. So, sodium in the distal tubule is important for the principal cells to have the electrochemical gradient that will increase the potassium excretion. So by decreasing sodium intake, there will be less potassium in the urine. They might falsely think that there is less potassium intake. So, if you go out and eat one meal, I think it will give more than, the recommended dose of sodium. I think that's the key. If you eat at home, you probably know what you're getting. So that's, the other thing is the reverse causation effect, which they have mentioned in the paper. That is, those who already have some cardiovascular risk or were warned by their physicians or family members about their impending risk, cardiovascular risk, might actually decrease the sodium intake, and that might make it look like, and they might have higher events, and they might look like those who have low sodium intake have increased events. So they call it a reverse causation effect. And the other thing is, the authors themselves mentioned that, they did not look at all the barriers to healthcare in some of these patients, like socioeconomic status, etc., which, I know Surya did mention some of the drawbacks. So, but I think overall, it took a lot of grit for them to go through all the studies, not as much as what Dr. Salim Yusuf did, because he really did a prospective study, but equal amount of effort from Surya to go through the whole thing and make sense of it for all of us. And thank you for that. And that's all I can say.
Thank you, Dr. Baskin. I think we have time for a couple of quick questions or comments from the general audience. Please unmute yourself and go ahead. We have the experts ready to answer your questions.
If there are no questions, if I may make a comment, Surya, it was an amazing presentation. It's not just the content, and all kudos to your mentors. I'm sure you worked with them really well. You made it very simple and very easy to understand. You kept that sense of anxiety in the audience. So you introduced the topic, and in the introduction you connected with the audience with your biryani, and you didn't really give away the results completely. So you kept that inquisitiveness in the audience. And I really like the slides, how you presented it. It was not overcrowded. I like the font you used. It was easy. So a lot of very good qualities of a very high quality presentation. Thank you for doing this. And thank you to the mentors, Dr. Krishnamani and Dr. Bhaskaran for helping out here. Amazing job indeed.
It is all Surya's work. Wonderful job.
It's all Surya's work. That's what I would
Yes.
say. Our job was very easy because
Right.
she truly is the expert today.
Yeah.
Wonderful, guys. So I think we have successfully presented our first paper. This is the first in the series of journals that we'll be doing as part of our AKMG Journal Club educational sessions. Our next paper is a very topical subject. Our own Dr. Johnson Thomas, who's member of the AKMG Education Committee. He's going to talk on his own research work on AIBx, artificial intelligence modeling to stratify thyroid nodules. Most of you know Dr. Johnson Thomas. He's currently the section chair for Mercy Endocrinology at Springfield, Missouri. He practices in general endocrinology, but he has a focus of his area of interest is thyroid nodules and thyroid cancer. He's also interested in radioactive iodine-resistant thyroid cancer, molecular markers, and most importantly, the use of artificial intelligence in thyroidology. He also created, very interestingly, an iPhone app called EndoTools. And this is basically meant for endocrinologists. It's a machine learning tool to predict thyroid cancers, which is very popular. So today, Dr. Thomas will present his own paper, AIBx, Artificial Intelligence Model to stratify risk in thyroid nodules. Dr. Thomas, please go ahead.
Let me share my screen. Are you able to see my screen?
Yes, sir.
Oh, thank you, Dr. Jacob and AKMG for giving me this opportunity to present my paper. So as Dr. Jacob said, today I'm going to present AIBx, Artificial Intelligence Model to Risk Stratify Thyroid Nodules. Hopefully I can make it, okay. So disclosure, I own the patent for the technology behind AIBx. So today we'll talk about the utility of artificial intelligence in classifying thyroid nodules, and we'll talk about the results of our study. So most of you know, we have a lot of patients with thyroid nodules. 1 out of 2 women over the age of 50 has thyroid nodules, and in certain population studies, up to 67% of population may harbor a thyroid nodule. And nowadays we are doing a lot of CT scans, ultrasound, and other imagings, and we are finding these thyroid nodules as incidentallomas. But only about 5 to 10% of these nodules are cancerous. And we are doing millions of biopsies every year to find this small amount of thyroid cancer. When a physician is faced with a thyroid nodule, we need to decide whether we can observe this nodule or whether we need to do an intervention like a biopsy. So different medical associations have come up with different options or risk stratification methods. American Thyroid Association has their own guidelines. American College of Radiology has the ThyRADS classification. So you can use these risk stratifications methods to figure out whether a nodule merits biopsy. But this is very subjective. If you give the same ultrasound images to 2 different physicians, you will get 2 different answers or 2 different probability for malignancy based on these criteria. And studies have shown that if you show the same thyroid nodule to the same physician, let's say 6 months later, you might get a different answer regarding the probability. And we cannot classify all the nodules using, let's say, ATA algorithm. You can only you will miss about 16% of the nodules. You won't be able to classify those. And most of these has low specificity and positive predictive value. What that means is when this classification system says that, well, go ahead and do a biopsy, there is a high chance of malignancy. Most of the time, it doesn't turn out to be malignant. So we are doing a lot more biopsies than what we really need. And if we use 2 different risk stratification systems, there are actually more than 10, you might end up with very different probabilities for cancer. So there is no uniformity in these things. So as the saying goes, well, beauty lies in the eyes of the beholder. So, if 2 different readers look at it, you might get 2 different results. Now, let's say we decide to do biopsy based on this risk stratification. Even then, 1 out of 7 nodules does not have a definitive diagnosis. This could be due to being non-diagnostic, having not enough cells, indeterminate, meaning it's kind of in between cancer and benign, and sometimes it comes back as suspicious. So it's not enough to call it as cancer, but it has suspicious features. Now, in summary, we are doing millions of thyroid biopsies based on very subjective criteria to find thyroid cancer in a very small percentage of population with an invasive technique, which may not be diagnostic 1 out of 7 times. And the questions as physicians we should ask is, are we actually improving mortality or morbidity? Thyroid cancer, the 5-year survival rate is 98.6%. So, doing these surgeries and all these procedures doesn't actually improve the outcome. In Japan, they are actually doing active surveillance for thyroid cancer. Even if they biopsy, find out that there is actually cancer, if the nodule is less than 2.5 centimeter, it used to be under 1.5 centimeter, they give the option of not doing anything and just observing these cancers. So our research question was that, based on this problem statement, can we create a reliable, explainable, non-subjective, and a non-invasive technique to address this problem? So we decided to explore artificial intelligence as a potential solution. There has been multiple studies showing that AI algorithms could match the performance of radiologists in classifying thyroid nodules. This was done by radiologists and presented in their radiology journal back in 2019. And multiple AI algorithms have been created to predict thyroid malignancy. But the problem is, if you give an ultrasound image to these algorithms, it will just spit out a diagnosis, benign or malignant. So how do you trust this? How do you trust an algorithm which says that, don't do a biopsy? So it was hard for physicians to incorporate this into practice and explain it to the patient. So that's the reason we chose a different route rather than the general paradigm that's happening right now. So I'll talk a little bit more about the study, participants and stuff like that in this slide. So we included thyroid ultrasound images of patients who underwent either thyroid biopsy or thyroid surgery in our institution and had a definitive diagnosis of it being benign or malignant from February 2012 to February of 2017. We had about 482 nodules, and we collected 2,025 images from these nodules. And the testing set had 103 nodules, which was collected from March 2017 to July of 2018. And most of these nodules underwent surgery. So we have histopathology as the gold standard here for the ground truth. 67.6% of the nodules in the training group underwent surgery and 61% in the testing group. And the prevalence of malignancy in the testing set was 32%. We had about 24 papillary thyroid cancer, 3 follicular cancer, 4 Hürthle cell cancer, and 2 medullary thyroid cancer in the testing set. So we used a deep learning technique, and the backbone of this is convolutional neural network. Think of it as passing your thyroid ultrasound image through these different layers, and each layer extracting a certain feature, let's say margins or microcalcification. And finally, it will spit out a result, whether it's malignant or benign. So we decided to take the penultimate layer, the fully connected layer before the actual prediction, and use this as a unique representation of that nodule. So this kind of becomes like a fingerprint of this nodule. And we store each of this fingerprint of this unique feature vector for each of these nodule in our database. And when we get a new test image, we create a feature vector, this unique fingerprint for that nodule, and then compare it to our database and find a nodule that is most similar looking to this test image and brings out the diagnosis along with it. So you can say, I want to see 5 nodules that are very closely looking to this test nodule along with the diagnosis. So the reason we did this was very similar to what we do as humans. So if you ask an expert, how do they make a diagnosis or a judgment call? Most of them, they will say, well, I look at it and it looks like malignant. So, that's the reason I decided to biopsy it. And we can all give different reason. Okay, I did this ATA classification system or ThyroIDS classification system, but most experts have an image of how a cancerous nodule or a benign nodule looks like. So this system is trying to emulate that and helping less experienced operators showing this database. And then the physician can decide whether this makes sense to do a biopsy or not based on the similar images that they are seeing. So this is how it is. You actually give a test image. It will pull out 3 similar images. As you can see on the top right-hand corner, it's the same exact image as the test image because this was done on the training data set. And then if you look at the images below the top one, those are the similar images along with the actual diagnosis. And then the final output will be this nodule resembles a, let's say benign nodule here in our database. Now we want to make it, we tried the normal paradigm initially, that is to give a result, benign or malignant, based on the prediction from the AI algorithm and give a heat map. So when we put that out in 2019, people were still using heat maps, and we're still using it. But there have been a couple of recent articles in famous journals these days saying that we should not be using this. And we kind of found the same thing back in 2019. If you look at the right-hand side image, it's a cystic benign nodule. And we told the AI model to explain by showing heat maps where it's actually looking at to make the diagnosis of it being benign. And you can see that it's actually honing in on the cystic area and the reverberation artifact on the lower part. So this was actually classified as benign, and to an expert, it makes sense. But if you look at the image on the left-hand side, this was actually a malignant image, a malignant nodule, and the AI model predicted it as benign. And if you look at the heat map, I'm not really sure where the AI is looking at. So it doesn't create explainability. So that's the reason we went with using similar images rather than just giving right-away predictions. And coming to the results, AIBx had an accuracy of 81.5%, had a sensitivity of 87.8%, specificity of 78.5%, and positive predictive value of 65.9. Also had a good negative predictive value of 93.2%. So when comparing this to the regular FNA, which is the standard of treatment or standard procedure that we do when we see a patient with nodule, FNA has a false negative rate anywhere from 1.5% to 11.5%. So average is about less than 5%. So a negative predictive value more than 95% will be very comparable to FNA. And in this day and age, when we are actually observing thyroid cancer up to 2.5%, by using a non-subjective method like AIBx could reduce the number of FNAs and diagnostic surgical procedures, thereby decreasing cost for care. Now, we had some false negatives, but those false negative results were actually benign-looking malignancies. For example, follicular variant of papillary thyroid cancer looks like a benign nodule. There was one cystic papillary thyroid cancer, which will look benign cyst to anyone. And there was one Hürthle cell cancer, which was in the false negative test. Now, the problem with AI in general is it may not be making predictions based on medically relevant things. For example, when there were researchers looked at pneumonia prediction, the AI model was looking at where the X-ray was being done. So it could see that the location was in the ICU, and it automatically figured out they have higher acuity, and it predicted those as pneumonias. And it ended up having higher accuracies, but it was actually not looking at a medically relevant information. Now, most of the AI models that we have these days are not explainable, and to create trust in these models, explainability is important. In our study, we only used 4 major ultrasound machines. So it has not been tested in wide variety of ultrasound images. And as you know, different machines have different hue. Some looks bluish, some look, more blackish. So without doing those kind of studies, it's hard to say whether this can be generalized. And we have not considered clinical history. So a patient who had family history of multiple endocrine neoplasia or radiation history to head and neck region has definitely a higher risk for thyroid cancer, but we are not considering any of those things. And none of these things will ever be 100% because the underlying ground truth being cytopathology or pathology is never 100% accurate. And when a physician actually looks at thyroid nodule, or for that matter, any other lesion, they don't just look at one static image, they look at a series of images. And let's say if we have a partly cystic thyroid nodule, in one slice, it might actually look benign, and in the other, where there is more cystic area, in other area where there is more solid area, it might look malignant. So it's hard to make a diagnosis just based on one image. And we also do like video analysis and real-time ultrasound where we look at lymph nodes and we use color Doppler. So all those information are not included in this current study. But what we have here is a different paradigm where physician is put in charge of all these things. This is not an autonomous AI where the physician can look at these images, and select an image which looks most suspicious to him or her and send it to the AIBx algorithm. AIBx algorithm will find, n number of similar images, and the physician can look and compare their image with the similar image and see whether it makes sense to accept the diagnosis provided by AIBx, and finally proceed with the intervention or not do any intervention at all. And the advantages are, well, in traditional AI models, if you have more data, you need to retrain the model, and there could be something called algorithmic drift. Here, we don't have to do that. We just put the test image into the algorithm, get that feature vector or the fingerprint, and transfer it to the database. It is very intuitive and explainable. When people ask me, how to explain this, I usually tell them, hey, this is like Google image search. You just put in an image and medical image, and you get similar images with the diagnosis. So it's very similar to Google image search in that manner. And we can use this not only for diagnosis or treating patients, we can also use it to teach residents and fellows and show them these features. And if we add more data to the database, like mutation history or like, what was the prognosis, we can pull out and show all those results. The limitations are it actually needs a little bit more computing resources and time rather than doing just the image prediction. Our test set only had 103 images, so it's a smaller test set, and there could be a lot of selection bias. We didn't biopsy all the patients who walked into our clinic, so there is definitely selection bias. And when this research was published in 2019, there was lack of external validation. Now we had national and international studies validating this. But in conclusion, artificial intelligence in thyroid image classification is rapidly evolving. It is still not completely, it's not non-subjective, it's still less subjective. And it's more or less like facial recognition for thyroid nodules. It acts as a decision support tool for the physician. And potentially it could be initially used in this indeterminate non-diagnostic nodules, and in the future, probably as a screening tool. Now, this is just a small curious slide. We all dream when we go to sleep, right? So can machines dream? Well, AI can, sort of. So this is computer creating thyroid nodules, kind of sort of dreaming. So I gave our database to the AI algorithm, and this has drummed up all these new ultrasound nodules that it has not seen using something called generative adversarial network GANs. And this is the final results. If you have any questions, I'm happy to answer. If we have time, I can show you a demo of actually how it works. Oh yeah, I'm assuming that we have.
Thank you, Dr. Thomas. That was an excellent presentation. As I started off saying in the beginning, it's a very topical subject. We are going to see incorporation of artificial intelligence in most specialties of medicine in the coming years. Already in my specialty, radiation oncology, we are seeing the use of AI in a big way. So we have enough time for questions, and also we have time for Dr. Thomas's demo. But let me quickly ask you one question, if I may. So the predictability of your model, was it the same for different histological subtypes? Because I know the numbers of medullary carcinoma and follicular were limited compared to papillary, which is the commonest histological subtype. So that is the first question, predictability by histological subtypes. And the second question is, how do you, I know you don't have the data, but how do you think the AI predictability is going to impact your diagnosis and prediction when it comes to, say, follicular carcinomas, where histopathology is very important, because you have to demonstrate invasion to distinguish between benign follicle and malignant follicular carcinoma. So how does that impact your diagnosis using the neural network AI software that you talked about?
That's two great questions. First one was to figure out whether there is an impact on histopathological diagnosis. Absolutely, because even if we don't even do AI, and if we ask radiologists to read this, papillary thyroid cancer, the classical variant is very easy to diagnose, for an experienced physician, because it has its own various features, irregular margins, microcalcifications, all those things. But if you look at follicular variant of papillary thyroid cancer or follicular cancer, it kind of looks like very similar to benign nodules. And it's hard to diagnose, especially follicular cancer, just by doing biopsy, because as Dr. Jacob pointed out, you have to show invasion. Now, our training data set was enriched with the classical papillary thyroid cancer. But in external validation study, we have confirmed that it is more, the AI model is favoring the classical papillary thyroid cancer more than follicular variant or follicular carcinoma. This could be ameliorated in the future. by adding more data from follicular cancer, medullary thyroid cancer, etc. Because unlike a predictive algorithm where it spits out one diagnosis, here we are trying to find the most similar images. So when this was tested out recently in a New York institution, they were surprised that many nodules that looked benign, AIBx called it as malignant because it was able to compare it with follicular carcinoma. But even then, we still don't have a large amount of follicular cancer or follicular variant of papillary thyroid cancer or medullary thyroid cancer in our data set. So that is a very, very relevant limitation. But it'll be hard to obtain a very large number of those nodules because, well, as such, they are not very common. So the second question was, for those invasive nodules, we should be able to actually give a diagnosis even for follicular carcinoma because the AI can pick up cues which we are not able to pick up. So that's what we are hoping. And, it has to be evaluated in prospective trials. So we have conducted few retrospective trials now, international and, internally in the United States. But we are planning a prospective trial to evaluate, how this will impact the clinical decision-making of physicians. So incorporating AI and how physicians will interact with is a different beast comparing to do a, clinical research. So that's something we are interested in finding out in the future.
Wonderful. Thank you, Dr. Thomas. The floor is open. Please unmute yourself and you may proceed with questions.
I cannot tell you how relevant this topic is. We come across this all the time when we do, pre-transplant evaluation for candidates, and they do a carotid Doppler and shows up with thyroid nodule, and then we are stuck with it without a biopsy and proving it's not cancer, and then end up getting surgery. And a lot of, as you said, is mostly non-malignant, but there's no way to tell at the moment without an invasive procedure. And this will be really great. And we are really, as Roji said, we are really worried about the follicular, papillary, hopefully won't cause it's not a life-limiting disease, but great presentation.
Thank you.
Johnson, if I may ask, what are the medical-legal implications of this? If there are issues, just to ask for, the general interest of things, if there is an issue or a problem or somebody sues, who is responsible? Who will be sued, the algorithm or the doctor who used it?
Well, that's a great question, and we still don't have a good answer. But most of the companies, what they do is the onus of judgment goes back to the physician. So just like even doing biopsy, biopsy comes back as benign. In about 3% of the cases that we see here in our institution, it can be malignant. But most of the time, and that's because we thought that nodule could be malignant, and we send the patient to surgery even after getting a benign biopsy. But there could be other nodules which came back as benign, which was actually malignant. So it's very similar. If you ask me, using AI technique is just using any other diagnostic test. We had to look at the specificity, sensitivity, negative predictive value, and the prevalence of the disease in your population to make a decision. But right now, the onus is mostly on the physician because they are making the final call. But this might change. I give you a different perspective, a different example, I would say. There are autonomous AI systems. For example, in diabetic retinopathy, which, as you all know, it's very common. The first AI algorithm to get approval from FDA was IDX. And that is a completely autonomous system. The physician does not participate in the decision making. So in that case, we still don't know, where the legal system will fall. But here we put physician in the loop, not only to take care of that part. It was mainly a clinical decision to make sure that we're picking the right images, and then finally the physician makes the diagnosis. But for autonomous AIs, that's still a unresolved issue. It's just like Tesla crashing into another car. Who is responsible? So, well,
so if I
Go
can
ahead.
just ask a follow-up question on that. So you mentioned that along with the diagnosis, and you would show what it is based on with your heat map. That was one way of doing it. But would you also, maybe you're doing it already, do you also give a sort of a confidence of how correct you think this is based on the number of images you have and the type? For example, some you may have confidence of only 60%, while some maybe 95% you're confident. Would you give that also to aid the physician?
So that's a great question. And in the first model, which was very subjective, we created something called thumb score. There you actually get a confidence interval and what's the probability. But what we found out was that, and many researchers have found out that the probability of, to go back a little bit further, so most of them, they have a cutoff, these algorithms. Let's say if it's 51% probability, well, they call that, malignant. If it's less than that, let's say we call it benign. But the probability might range widely even for a malignant nodule. It could be anywhere from 99% to 51.1%. So, but all of them were malignant, right? And so so when we try talking to other physicians, so if they see a 51.2% versus a 99%, well, they'll probably be more confident. But that confidence in prediction did not actually translate to the actual diagnosis. So that's one reason we didn't actually include that. If I may share what we do, something with the newer version is, let me see if I can show it to you. So this is, hopefully you can all see my screen. This is the actual software. Let me upload a nodule, let's say. So this is a mixed cystic nodule. So you can see the black spaces inside, that's actually the cystic area. The solid area is this white area, and this is the whole nodule. And when I submit it to the AIBx algorithm, it's going to take a few seconds. So it will hone in on the area where the nodule is. And let me see if I can pull it up and enlarge it a little bit. Give me 1 second. So it will pull up that area where the nodule is. And then if you read just below it, it says the most similar image to the uploaded image in our database is a benign nodule. And then it also gives you a thyroid description. So it describes this as a mixed cystic, isoechoic because the solid component is where we rate it, and it's wider than tall, and its margins is kind of irregular, and there is no calcification. And finally, it also gives you like a recommendation based on the size, what needs to be done, should we biopsy it or not. But if the physician wants to figure out, well, is this based on a similar image? Because that's what we humans do. We compare it to our mental map of how a benign nodule looks like. So if they want to do that, click on this and you can find a nodule, which we have actually the diagnosis, which had a benign diagnosis. And it looks very similar to this image. There is cystic areas, there is white areas. And if you look at the second image, you can clearly see, well, it looks again very similar to this nodule. So even people who are not very much trained on this thing, they can visually compare the similarity, and each of those nodules diagnosis you can actually see on the top, and then make a decision for themselves. Hey, you know what? It looks very similar to their database, or sometimes it may not. And then they can say, well, even though it says it's benign, the similar images that they're showing does not really match. So maybe I should not rely on this. So there are some checks and balances in this program for that.
Dr. Thomas, one of the questions asked in the chat is how the software handles multinodular thyroid. So is it the same? Is it the same steps which are followed there?
Yes. So it actually can go into where the nodule is and hone in on it. Let's say you want to, it usually picks up the most dominant nodule and gives you the diagnosis. But let's say if you want to look at a different area, you can actually pull up the edit button. And let's say if I want, this is just for demonstration purpose. Let's say if I just want to look up here, and then you save that, you actually get a very different image and you submit it. So you can select which area you want to analyze in a multinodular goiter. But in the future, the plan is to give recommendation for each and every nodule that is clinically significant if you pass in that. Right now, it will hone in on the dominant nodule and give the result, but still you can use the edit function to pick a different area if you want a diagnosis of a different area.
Okay. Dr. Thomas, another question that Dr. Chittur Shivaram wanted to know was, what are the current training standards for certification in thyroid ultrasound scanning in endocrinology fellowship?
Oh, so there used to be a certification program that was done by American Association of Clinical Endocrinology, ACE, and that was in conjunction with AIUM and American Radiology Association. But that program kind of died down because of lack of interest in the last 2 years. But during our fellowship training, most of us get trained in reading thyroid ultrasound and doing biopsies. But people who are really interested in, they can actually get different certification. But after the ACE course died down, there is no, I don't know about any active certification course that's available right now.
Thank you, Dr. Thomas. Excellent presentation, wonderful paper. I want to remind everybody that CME credits are available for our journal club. Please remember to claim them. We shall be sharing the link by email and and through WhatsApp. Now, I'm requesting Dr. Harun to give the closing remarks.
Thank you very much, Roji, and also Khalil, who have put this together. Thank you to the mentors who played an important role here. Of course, the presenters, Dr. Surya, Suresh, Dr. Johnson, Thomas, exceptional presentations. And thank you so much for kickstarting this series at such a high note. And thank you all for taking your time to attend the event. I do note the comments on the timing. We will discuss in the education committee if there is a better time to hold these events and which will be more convenient for a lot of people. Nevertheless, thank you all for taking your time and attending. We will have more programs. Roji and Khalil are so enthusiastic to bring us and teach us a lot of things through the year. Thank you very much.
Thank you.
Thank you.